butyrate. Some of them are neurotransmitters that may go up to the brain. Some of them are cytokines that are formed that have an effect on immune modulation. Some of them are going to have an effect on metabolism and insulin resistance. And, as I've talked about, we see the interrelationship between the gut microbiome and immune system regulation is something that's been very well characterized, that we continue to deepen our understanding of. And then some of those postbiotics, those metabolites, will be eliminated as waste, as part of what goes on normally. And so when we're looking at a balanced microbiome, we have to look at, well, what are the nutrients that we're taking in as prebiotics? What is happening with the commensal flora in the overall balance that's there? And do I need any additional support with other probiotics that may be necessary to be able to deal with specific disease states and imbalances that are occurring? And as we'll see over time, we'll begin to measure the postbiotics as a true definition of, is there balance that's going on? Now, I mentioned earlier that diet, the middle of the taproot, if you will, of the tree, of the functional medicine tree, that is the most important modifiable lifestyle factor we have. We know that. We know that food as medicine is going to affect the gut microbiome. But again, we're now seeing data that's come out. I was approached about 4 years ago, to look at, well, what's the data on exercise and the gut microbiome? And it's hard to distance it. It's hard to separate it out from dietary patterns. But when that's been done, we can see that exercise itself has very specific beneficial effects on the gut microbiome. And depending upon the type of exercise, also will have different kinds of effects on the different organisms that are there. And we see treatments that are helping athletes, high-level athletes, be able to refine their gut microbiome and improve their overall performance activity. We know that there's a relationship with stress, and we know that there's and the vagal nerve and the migratory motor complex and what's happening there, and permeability. So we know that we can actually have an effect through the gut-brain microbiome axis to be able to cause shifts in the awareness and in the behavior that we have overall. So let's come back to the case study for just a moment. So within the case study, this young woman, we saw all of what was going on with her. And the first thing I said is well, first let's getting you eating a diet, the color of the rainbow, Roy G. Biv, all the colors that are there, whole foods, and focus on probiotic and prebiotic rich foods. She'd had been intolerant to chicken before, intolerant to onions and garlic, intolerant to nightshades. So we removed those. That in the reintroduction phase, we did not reintroduce those because she'd had issues with them before. These may be foods, particularly the onions and garlic, with their prebiotic effect, and the nightshades, that may have had an effect on the abnormal growth of gut microbiome for her at that point in time. So we're very cautious about that. Now, that was the first phase. Then we worked to treat the parasites, the blastocystis hominis that she'd had repeatedly, treating it, as I've talked about, with nitazoxazide, 500 milligrams twice a day for 10 days, and oregano oil. I usually do 200 milligrams 3 times a day for 10 days. In this case, it was 300 milligrams for two times a day because of the products that were available, and treating her gut during that period of time and supporting with Saccharomyces boulardii to ensure that there wasn't some further alteration of fungal overgrowth that could occur. We find that there is an interesting overlap. About a third of the patients with bacterial overgrowth will also have fungal overgrowth, and then used a combination probiotic therapy. Now, this was a few years ago. If I was doing this today, I probably wouldn't use that combination probiotic therapy. I would have just used the Saccharomyces boulardii with her. We saw decreased pancreatic enzyme, exocrine pancreatic insufficiency. So she has to have enzymes. And this is a fairly high amount of enzymes. But when you see severe pancreatic insufficiency, you need that. Gave her oxbot. We saw the question with Liz earlier. She was demonstrating some issues where there was a fat malabsorption. So we gave her bile as well and gave her Swedish bitter. So this is like a full court press on the maldigestion side of things with her. She didn't have any inflammation that we could see, but she did have a decrease in her overall immune function. And so when we come to look at the overall decision trees that we're doing, we say, well, how do we evaluate? How did it work? So there's a couple different ways in which we looked at. And so one of them, we've talked about the multiple symptom questionnaire. I'm more of a fan of the patient reported outcomes measures developed by NIH. And what we saw at 6 weeks was her symptom questionnaire, her number went from 108 to 42. But even more importantly for me was that her PROMIS scores improved from, she was in the 4th percentile, meaning she felt better than 3% of people in the United States, to the 38th percentile at 6 weeks. And her migraine score, what's called the HIT-6, went to 0. Number, or actually not yet. I'm getting ahead of myself. It dropped down about halfway. Score of 36 is completely normal. Her joint pain was improved. Her brain fog was improved. Her diarrhea had resolved. She was still having some energy issues. She was hesitant to move forward. At 12 weeks, 3 months in, she had a MSQ of 22, down in a normal range, a PROMIS score, a global PROMIS score in, better than half of the people in the United States, and a migraine score that's essentially 0. 36 means your baseline. And so we saw some incredible improvement that happened with her during this period of time. So excited about it. And, I can say that, she's had issues that have come and gone. When our patients get better, they don't just stay better forever. Sometimes they fall into old behavior patterns and we have to work with them over time. That's normal. That's human life. So I want to kind of wrap this up by talking about, well, what are the sticky points? I've talked about dysbiosis. It's not a disease, it's an imbalance. And it can have effect not only on the gut, but also on the whole body. And when we're looking at dysbiosis, I talk about it by saying, who's there? What's the census of what's going on? When I look at the culture, I say, who's working in the economy? And I look at the metabolomics, whether it's the butyrate, short chain fatty acids, or other aspects. I'm saying, how much money's circulating in this economy that's going on? Is it depleted? What do we need to do here? Or is it in the wrong places? I'm trying to see, are there parasites? Is there a yeast overgrowth that's happening? So I've differentiated between GI dysbiosis and pathogens. They're not the same thing. Sometimes we need to treat pathogens. Sometimes there's pathogens and we need to treat them. And so that's part of the weeding process that we're going to do. But one of the other things I want to highlight is that I've observed that there's this intrinsic interrelationship between the microbiome and the immune system and the mitochondria. It's not talked about here, but in my work with long COVID, I continue to find that we know that immune microbiome issue, but the mitochondria is intimately involved with it as well. So in order to bring balance back to our patients using this dig in kind of approach, and then these 5 R's of remove, replace, repopulate, repair, and rebalance, that in order to be able to bring beauty back, and I love this picture. It's from Yellowstone National Park of Grand Prismatic Pool. And the balance that's present here, these are cyanobacteria that radiate at different temperatures of the water. The deep blue in the middle is boiling water in Yellowstone. But as the temperature cools, there are different cyanobacteria that radiate different colors. And for me, it's a thing of beauty. It demonstrates that when our microbiome is in balance, that it's beautiful, and we have the opportunity to optimize our health and well-being. So I want to invite Dan and Liz to come back, and we'll have a little conversation. Sound good?
Excellent. Nicely done. Ozone mitochondria, mitophagia, autophagia. We'll talk a little bit about that. All right. Good to go.
And you can see that if you didn't take that 1 minute on the front end, I would have ended exactly
on top. But thanks for reminding me of that. I appreciate that. Are we on? Excellent. Thank you. That was excellent. I thought it was excellent. So
And there's more.
that's right. And there's more. So we're going to go to just a few questions, a couple of cases, and get in a few questions from our colleagues out in virtual land. So, Liz, why don't you kind of answer this question from, obviously, Patrick just gave a very nice presentation on dysbiosis. When do you consider dysbiosis?
Yeah,
How do you do that?
Yeah, so I'm wondering, is there dysbiosis definitely when a patient comes in and has some GI symptoms, right? They come in, they're complaining about bloating, diarrhea, constipation, any GI symptoms. I'm wondering, is there dysbiosis, right? But I'm also, and Patrick really laid this out for us, really, definitely thinking about it when there's autoimmune disease, because we know that some dysbiotic bacteria or bugs can be involved in triggering or continuing mediating autoimmune disease. So I'm thinking about it in autoimmune disease. I'm thinking about it even in metabolic syndrome, since we know dysbiosis may be impacting that. And I'm thinking about it with any inflammatory process, eczema, eczema and acne. And so, yeah, I think about it a lot.
You think about it a lot. So, and Patrick, you obviously talked about it a lot. Is there a particular way in which you say this is dysbiosis from a particular laboratory parameters? Is it clinical and lab? And do you ever rule out dysbiosis? Are there places that you say, oh, no, it's fine?
There's certainly occasions where I've had patients who don't have dysbiosis, but the nature of Liz's practice and my practice is they're often people who have seen many practitioners. They're fairly sick. And so in those cases, almost always there's dysbiosis of some form. I don't know what it is. I don't know if it's related to parasites or yeast, or if it's an excess or deficiency that's going on. But I also wanted to say that I've actually changed my practice in the past 7 years since being at Cleveland Clinic. And that is that, I first actually aggressively work with diet and see where the person's at a new set point. And then if they're still having issues, then I figure out what's going on with their diet. Which, kind of it's, I could do all at once, but since I'm going to be making dietary recommendations, I sometimes don't know, well, how much did the dietary recommendations that I started with for the first 4 weeks have already improved things that I tested 4 weeks ago, and now I'm treating something old. So, I've switched it a little bit, and there are exceptions to that, because if someone comes in with, inflammatory bowel disease, or someone comes in with other, major, some really acute autoimmune disease, I'm going to be more aggressive with figuring out what's going on with the gut right away.
Gotcha. Dr. Boham, I'm going to turn the mic or the clicker over to you, and you can go through this case.
Yeah, so we thought we'd do another case here just for fun, right? And this is a woman who came to see me, 60-year-old woman, and she was complaining of chronic pain that started around the age of 52. And she says that she's got this burning on her legs, left side of her body, her feet, and she had seen a rheumatologist and had a workup that did show positive ANA and a positive rheumatoid factor, but was it didn't, the rheumatologist didn't feel that she needed any further treatment at that point in time. And so she came to us saying, okay, what else can I do? She has a history of a lot of antibiotic use, definitely the standard American diet, not a very healthy diet for many years. She reports that when she was 23, she had this bloody diarrhea after a cruise and was treated for a parasite, and that seemed to help her symptoms, but has struggled with constipation really her whole life. And you're going to see here on her matrix, there's a lot of focus, or a lot of ink, as we would say, in the assimilation area and defense and repair, and maybe even in toxic exposure. So I'm going to show that to you here. So here is her matrix, and how I filled it in. You see that she had a lot of antibiotics growing up and in early adulthood. She was hospitalized at age 13 for 3 weeks with a gut infection and lots of antibiotics. She would have urinary tract infections with her pregnancies and needed to actually be catheterized, and had lots of antibiotics for that as well. As you can see here under defense and repair, she had these skin lesions, the antibiotics frequently. She had a positive ANA, a rheumatoid factor, but her workup didn't require further treatment. She had normal inflammatory markers. It was kind of interesting too. She really struggled with the mental, emotional, and spiritual well-being. She had a lot of anxiety around medical issues, and she had a lot of worry around those. And so her relationships with her friends weren't as good as they could be. They felt that she always was complaining a lot about her symptoms. So there's a lot more on here, but with the fact that she had these autoantibodies and a history of a lot of antibiotics, I decided to do a stool test. So here's just the stool test that I did with her at that time. And what we're going to see here is we see that she had high levels of fecal fat, so high fat in her stool. We also see here that there's a relative abundance in her commensal bacteria. So as Patrick was explaining, we can see, high levels. It's a little bit higher than normal. I mean, you see that on the left-hand side of your screen, and a lot of highs there on the right-hand side of your screen. And she had some bacterial overgrowth. There's some levels of bacteria like Citrobacter and Klebsiella that showed high on the culture on her stool test as well. We did, there was also PCR testing for parasites and a culture for parasites that were all negative on this stool test. So what we see, in terms of the stool test is we see that there's this dysbiosis going on, and I had concerns regarding this dysbiosis and felt like we should do something about it because of this autoimmune predisposition that she had, those autoantibodies.
So why don't you answer the first question here, Liz, is
what is my diagnosis? Right. So I've got a woman who has positive autoantibodies and has this dysbiosis. So I guess, Patrick, what else do you want to know?
Well, I'm already guessing that she's got some permeability issues that are going on. I want to better understand her diet. I want to try to get a sense. I mean, we see this sort of excessive dysbiosis and the patterns that are there. So I'm going to now be in a conversation that's like, okay, so do we need to, how strong do we need to be able to tamp down, right? And when you have that excessive dysbiosis going on and Citrobacter and Klebsiella, you're not going to fix that just with diet and prebiotics. So how far do we need to go, and how do I work with that? I look at the patterns that were there. I'd work with permeability and considering that, but I'd also be trying to really understand what is her primary concern. Mm-hmm. And being able to help drive and help her in that way, because I think we can help with the dysbiosis and the permeability issues. but I'm not really clear on what her primary concern
I
is.
mean, her primary concern was this body pain and, the burning and the body pain that she was having, and what else could she do to feel better? And so it's a very good question. And I struggle every day, or I'm always thinking every day, okay, how aggressive am I going to treat this? We found a dysbiosis here. I'm concerned that it's contributing to her symptoms, and how aggressive do I need to be when I'm treating it? So
what did you do?
what did I do? I mean, I used an herbal approach, right? So, there are times when I might use a prescription, Xifaxan or Diflucan in this situation, or just Xifaxan. But I did use an herbal approach and used a combination of herbs. You were talking earlier about the combination that Dr. Mullen put together and has done research on, which is, do people have access to that?
Yep, that's in the Dr. Asimov's presentation on SIBO. Are you talking about that?
That's the one. Yep.
So there's that article reference there.
Okay.
About that a bit.
Yep. And so that's what I used for 6 weeks with her, because I felt like, okay, I want to really help her symptoms feel better. And I worked with her also on an elimination diet, just to lower the inflammation, because there's a lot of inflammation going on now. As you mentioned, we suspect there's increased intestinal permeability. She's got these infections. And so we did an elimination diet with some herbal approach to help with her inflammation in her body and help her feel better.
Roy G. Biv.
Yep.
So I think that we'll do one more case. Now, I know there's a lot of questions, and we will get to some questions. I want to remind you that Patrick and Liz, but talking specifically about dysbiosis, we'll be doing a Zoom chat. So there's questions on, would you use spore probiotics? Do you use spore probiotics? Those kind of things. We'll get to those at Zoom chat. I think it just would be instructional to spend the last couple of minutes on just this other case vignette. I think it's got some good takeaways to it. So let me read this, and then we'll go back and forth with Patrick and Liz. So we have a 36-year-old female presents with complaints of intermittent loose stools, pain and bloating, 3 years duration. You decide to do a comprehensive stool analysis. It shows beneficial bacteria deficient, potentially pathogenic bacteria absent, opportunistic bacteria present, total short-chain fatty acids normal, and N-butyrate deficient. So this is a kind of dysbiosis I think we often see. So the question that I'll first turn to you, Liz, is what else do you want to know here? Is there something else you want to know? And then we'll turn it over to Patrick to what's the treatment option in this kind of situation.
What I always want to know, right, is what is her diet? What is she eating? What has she tried to eliminate? Has she tried to eliminate anything in the past? How much can we impact how she's feeling with shifts in her diet? So I need to know a good diet history on her.
Okay. Go ahead. So Ben, I want you to answer this second questionnaire. What are the treatment options that you would consider in this? And you talked about this kind of dysbiosis, which is the predominant. There's not a bug that you're necessarily going to say,
right.
I'm going after that.
Right. And so it kind of defines right up front, I'm not going to be using an antibiotic or an antimicrobial. There's, a question of could it be parasites, but there's no parasites that are present. So now it's like, I really need to lift all boats. I need to help everything that's going on. And, we talked in that slide, it's like prebiotics, probiotics, postbiotics. So we could say, well, we could give butyrate, or we could give a postbiotic that would help. And maybe that would be useful in the short term. And I would probably do that in this case. Now, a probiotic, I wouldn't know what probiotic to give. Some people would say, oh, well, you can give Akkermansia because that will produce butyrate. But, that only does that for the short period of time that it's there. It's a relatively expensive intervention. But if I come to the prebiotics and say, well, what are the foods that I can use to really be able to help promote butyrate production that are anti-inflammatory in nature? And Dr. Leo Galland has some great smoothie recipes and things, and we have some in our toolkit that can do that. That's where I would be approaching things. So really focusing on the prebiotics and the foods, and what can I do to be able to add, generally when I'm seeing some intermittent loose stools, I'm thinking about acacia root, I'm thinking about PHGG, partially hydrogenated guar gum. Those are some of the big ones that I go to. When it's runny diarrhea, I go to potato starch, and so that it's differentially applying the prebiotics in there and focusing, as Liz said, on the foods.
Sí. Uy. ¿Tienes cabeza?
Creo que es esto.
No menos. Estás igual que lo anterior. Pero vas mejorando. O sea, la idea es que escribas como te enseñaron a escribir. ¿Cómo te enseñaron a escribir? Usando el ¿ven?
No. Pero estoy usando el recibo.
No. No.
Yo no me gusta que se vea tan...
Bueno, escribe bien. Lo importante es que entiendas vos mismo.
Sí, yo sí entiendo.
Ah, bueno, ya. Yo dejé aquí unas medias. Yo dejé unas medias, ya no hay. ¿Dónde? No, aquí. ¿Y por qué no han comido ustedes?
La mía no fue. Solo copié uno más. Una cosa. Está bien. Solo copié eso. ¿Esto de qué, niña? Esto. Mía.
Nadie come la tortilla. Ni uno, ni el otro, ni el otro. ¿Eso de quién es? Ven acá, David. ¿Qué traes a comer? Ahora la boca. Abre. Ahora lo que. Eso viene el pan. Ahora sí, eso viene el pan. Sí,
Está rico.
el avioncito. Ya, el avioncito. Una por el papá.
Papi, a veces sí cantando rico. Ahí la tienen la leche.
Ya. Ven también, Catalina.
No.
Por el papá.